Check, mic check.
This session, we have three presenters. Zaralam, Kasomari, Barak, Nachumanach. Saati Mali Tavano, Kachalaju, maximum Aslam Sega, Castam Sega Bano, or Pena. To the point, you such question at Osmatarabukat, such question at the then meted the finally managed. Now, but just focus on your recommendation. Thank you.
Okay, thank you, Dr. Musa. Good morning, everyone. Our title for presentation is Validation of Predictive Nomogram for Mortality among neonates with necrotizing intercolites in tertiary care hospitals in Bahar Dar City. Basically, this study was conducted by one of my students. So, as the presentation outlined, we have background, the objectives, methods, result in a discussion, and conclusion and a recommendation. Finally, we have acknowledgement. As the background, necrotizing intercolites is life-threatening gastrointestinal problem or disease among neonates, particularly affecting preterm birth. When we see the pathophysiological condition of this disease, it starts with ischemic necrosis of intestinal mucosa, especially the inner layer, and then progress to cause severe inflammation. And then this results in bacterial invasion into the inner layer, and then results in systemic sepsis and can result in multi-organ failure. So when we see the global burden of or the prevalence or the burden of the disease in general, the incidence varies from 5 to 15% among neonates with less than 1.5 kg birth weight, which means mortality is about 20 to 50% across the globe. And when we see the problem or the disease in our country, the prevalence ranges from 2 to 25%, and even the hospital mortality can be as high as 70% of the problem or infected cases. This high mortality is because of the prematurity and very low birth weight, and the neonatal sepsis and the prenatal asphyxia, and delayed diagnosis and limited access to care can contribute to the mortality. And knowledge gap, there is limited data on NEC outcome, particularly the one we interested in. So prognostic factors are also lacking for the study, for the topic. The impact, NEC causes prolonged hospitalization, severe complication, and like neurodevelopmental impairment. So high mortality, like from 45 to 89% of the case can happen in low-income nation countries. So the objective is to develop and validate a predictive nomogram for mortality for NEC, and then in order to improve risk stratification, stratifying patients or cases, and then guide clinical decision making, and then optimize resource allocation for this problem. As a method, we used the institutional-based prospective follow-up study from July to December 2024, and it was conducted in Talagayot and Tababagion hospitals. The domain is the neonates. Neonates in general from 0 to 28 days diagnosed with NEC. With stage 2 and stage 3 are included. And the exclusion criteria are those with stage 1 were not included. And the major congenital anomalies are also excluded. As sample size and sampling, of course, we use it, we included about 251 neonates, 104 from Pelagiot, and 147 from Tababagion. And then consecutive sampling was used. Consecutive sampling, as the case is rare actually. So about 90 candidate predictor or variables were included. So prognostic determinants that we included were like demographic and prenatal factors, clinical characteristics, hematologic parameters, treatment-related factors were included as a prognostic factor for the outcome. So when it comes to the data analysis and model development, we use it AP data to enter the data, then R was used for analysis. So the steps that we used, descriptive statistics analysis was performed, and the univariate analysis was done. Univariate analysis, we used 0.2 or 20% as a cut point for variable selection to develop our final multivariable logistic regression model. So we used the model performance evaluation using discrimination performance measures like the AUC, area under the curve, ROC curve, and sensitivity, specificity were also used. And as a model validation, the calibration was used, calibration plots. Cosmer-Lemenshaw p-value also used. And then we performed internal validation also. Internal validation using bootstrap sampling technique. So 1,000 resampling were done. Nomogram, we finally constructed a nomogram based on the reduced model. And then to evaluate public and clinical utility, we used decision curve analysis. So as a result section, we have included 251 units. About 84.1 were with low birth weight. And so, about 78.5 were stage 2 for NEC, and stage 3 were about 60.7. This is the final table that we produced from the original model as well as the bootstrapped model, meaning the original model and then internal validated based on the internal validated result. So the prevalence actually, or the incidence, we can say about 51% of the case, the mortality is this much, 51%. So I don't go to the detail because of the time. We finally, based on the final model, we produced the discrimination performance of the model. As you can see, the ROC curve produced about 96.5% of area under the curve. And then based on Jordan index, based on the Jordan optimal cut point, we produced sensitivity, specificity, and the predictive values, and even accuracy of the model. You can see the accuracy finally at the end, 89%, which is 89.2%. So the misclassification rate is only 10%, around 10%. When you see the original model calibration, this is predicted probability versus the observed probability. You can see that the red line is the ideal line, that's 45 line, and our model showed or followed this ideal line. So we can say it's well calibrated, and even a p-value was about 2.92, the Hosmer and the p-value, Hosmer-Lemenshaw p-value, which shows that it is well fitted between the predicted and observable probabilities. And then we performed the internal validation, and then the area under the curve for the internal validation 95%. The original we already 96.5, and the corrected one is 95%. That's adjusted or after bootstrap. And we can see the optimism coefficient, which is about 0.01, which is very minimal. We show that our model is well performant and can be applied in unseen population also. So this is the nomogram, and then we have written a sample how we read the nomogram. So this nomogram is be able to predict the risk of everyone that are included in the study based on the fact that, like, for example, if a neonate has gestational age 32, if Bayes stage in stage 3, we can add the scores. Then finally, we determine the probability of having the outcome or poor outcome or days in this case. So based on the sample I generated, you can see that 70% for the case for individual risk of developing an outcome. So then we classified, based on the nomogram model, we classified as high risk and low risk. This is also then based on the optimal cut point, that is for the nomogram. So when we come to discussion, the NEC mortality in this study is 51%, which is, of course, lower than previous Ethiopian report, like which ranged 57 to 82, but still alarming, very high. 51% is very high for 251 cases. Comparable to the other studies in Indonesia, South Africa, and much higher in UK, which is 80%, China, 14.2%. Of course, maybe this. Okay, thank you. So finally, as a conclusion, the nomogram performance, excellent discrimination, which is 96%, and good calibration and internally validated that can be applied even in unseen population. So clinical utility, this study enables risk stratification and targeted intervention. So supports the integration into routine NICU protocol. It's possible that because our finding is very nice, and the recommendation to the next step, maybe external validation is required. So in this population, even if possible. Incorporation into quality improvement initiatives emphasize early feeding, infection control, and intensive monitoring for high risk group of neonates. So then finally, we acknowledge Bahada University for the ethical approval, granting ethical approval, and Tawagion and the Palagayon hospitals for permitting us to conduct this study, and then data collectors, and then the finally the participants and the mothers and the caregivers. I thank you very much.
Thank you.
Okay, thank you very much. Good morning, everyone. I am Kasomar. I'm going to present a paper entitled Skeletal Burden of Malaria in Pregnancy in Amara region, Ethiopia, covering from 2008 to 2024. So I'll go through this presentation outline, starting from background, objective, later discussion, conclusion and recommendation, and finally acknowledgement. As a background, as you know, malaria in pregnancy is one of the major public health problems. In general, malaria has a problem for both developed and developing country, but it is more for developing countries, especially for low and middle income countries, including Africa. So it affects the vulnerable population like children under 5 and pregnant women. The pregnant women are more susceptible for malaria infection because of her physiology and the pregnancy related factors. So she is more vulnerable risk group as compared to the other population like non-pregnant women and the general population. Like 36% of pregnant women experiencing infection in worldwide. Why? Because pregnancy is a risk factor for her to because of her immunological change. When a woman becomes pregnant, her immunity, her immunological, there is a immunological change in the body and the physiological change as well that favorable for malaria infection and susceptible for the mosquito bite as well, and limited access for malaria pregnancy service also one of the contributing factor for this problem. So it has a problem for both the mother and the neonate, this malaria. When you see the maternal outcome, there is a maternal anemia, cerebral malaria, severe malaria, neonatal mortality. And when we see the child outcome, there will be abortion, stillbirth, placental delivery, low birth weight, and so on. So it affects both the mother and the neonate. Even the children after, if the children born from the malaria in pregnancy mother, the child will be affected in the in his or her development in the future. So 10,000 women die and 200,000 neonates dead because of this malaria. So malaria and pregnancy distribution vary across time and place. There is a seasonal and geographical variation and difference. The previous study mainly focused on the general population. There are few studies conducted in our setting, for example, but most of the studies were for the general population. But the general population and the pregnant women, malaria distribution, malaria risk, and susceptibility are very different, and the geographical and the temporal difference also is different from this group of people. So there is a limited evidence on malaria pregnancy distribution pattern and predictors in the study area Amara region. So this is objective, assess spatial-temporal pattern of malaria pregnancy and identify predictors in the Amara region from 2018 to 2024. It's a 7 years study. So study area, Amara region is the largest region in Ethiopia with a diverse geographical, temporal, and currently conflict affecting area. The conflict is going on, so this affects several things, including the malaria. And the data source, we have used different data sources. For example, the routine health data were obtained from Amara Public Health Institute, the malaria surveillance data, including the malaria in pregnancy, and district level NC data were obtained from district health information, DHIS2, district health information system, to from regional health bureau, and environmental data sets like rainfall, temperature, and other factors, other data were obtained from the geographical environmental station data, and the shape file, including the population number of the region, is obtained from Ethiopian Statistical Agency. When you see the variable, we have outcome variable, that's malaria pregnancy as an incidence across the year. And predictors were climate factor, NC1 and NC4, annual parasitics incidence, and temporal variations like months, season, and years were considered for temporal, and annual incidence were calculated from the calculation case, the total case. That means the pregnant women who have infected by malaria for the last 7 years were considered as a case, and the general population, I mean the denominator were the total pregnant women in each district for each year times 1000. So these are the calculations to use for annual incidence calculation for pregnant women. And we calculated for each year and each district. So when you see the statistical analysis, trend analysis of the incidence were employed. Scan poison based model were used for clustering analysis. The pure temporal, pure spatial, and spatial temporal clustering were used by SATSCAN poison based analysis, and Arimax, especially Arimax model 104, were used for time series modeling, and the model diagnosis were checked by AIC and BIC methods, and we used R for the analysis of this data. When you see the result, so between January 2018 to December 2024, a total of 53,478 malaria cases were recorded among the pregnant women from the total 160 districts that have accurate data. So the mean malaria incidence were 9.2 out of 100, I mean 1,000 population that is pregnant women, and the standard deviation were 3.38. So when we see the trends, so starting from 2080, it was 2.4 per 1,000 pregnant women. But when we go to the recent times, like 2019, 20 to 2024, so the malaria incidence is increasing. So, for example, when you see the 2022, it was 8.7, and the following year, that is 2023, 12.9, and the last year, 2024, it was 25.6. So there is an increment of the malaria incidences, and you can see the changes as compared to the baseline. So the last year, that is 2024, was nearly 982% increment. So when we see the temporal clustering, there is a significant temporal clustering in 2022 to 2024. So there were 3.7 relative risk, and the incidence were 70% higher than the previous. So you can appreciate how the malaria pregnancy is becoming a temporal clustering and becoming increasing for recent years. Again, we calculated the spatial cluster. That is the geographical location that have malaria in pregnancy clusters. So we identified 7 clusters starting from the Kwara. So the yellow color is considered as Kwara as a center, and other 5 districts are surrounding. So the second cluster were Dara, Pokhara, and Bahardar. Bahardar is also included. You can see the purple color near to Tana Lake. And we also identified other clusters like Avargale, Notasalam, Bazoliban, and the central Gondar highlands, Dabat, the 7th, including 16 districts surrounding with the Dabat, like Tagade, Dabat, Armacho. So these are the temporal, the spatial clusters.
You have 2 minutes.
Okay. Spatial temporal cluster again, we identify 7 spatial temporal clusters by combining both time and the space. So the earlier cluster were 2018 to 2020. That were clustered, localized and uh, located in different parts of the region. As you have seen, there is Abergele, there is Bazoliban, there are Kwara, around around surrounding Lake Tana, that's Bahardar, Zuria. But the latter cluster, that's 2022 to 2024, it covers a wide range expanded to northwest and central Amara regions, as you have seen this one, the red uh, pointers. So all the northwest and the central Amara is concentrated. So we can appreciate that this malaria pregnancy clustering is diffused to different parts of the region. So this study revealed distinct spatial, temporal, and spatio-temporal pattern, and there is not randomly distributed. So there is something that's favorable for this clustering, highlighting inequality in malaria exposure and potential gaps in intervention coverage. And service disruption, and climate factor may be contributed, especially the current ongoing war may contribute for this clustering. We computed the climatic and service factors by ARIMA model to check their predictor. So rainfall, average temperature, soil moisture, relative humidity, and elevation were the significant factors for this autoregressive pattern, as we have seen from this regression model. Again, we check the prediction of the next 1 year, that's for 2025 to 2026. So the model appreciates that there will be a remaining high malaria burden in the region, specifically following the main season to July and September. So the red line is indicating that the projection times are indicating there will be high burden of malaria again going. So as a conclusion, malaria pregnancy has increasing substantially to recent years, as we have seen from the clusters, and climatic, environmental, and epidemiological predictors, especially annual parasitic incidents, where explains this disparity. Targeted climate responsive intervention is essential for the intervention. As a recommendation, we recommended integrated malaria pregnancy surveillance with climatic data, because some of the climatic coverage were the predictors for this. And targeting high risk districts with early warning system. We have to integrate the early warning system with this malaria in pregnancy intervention, and improve antenatal care coverage continuity, specifically for high burden areas and conflict affected areas. And we have to increase the malaria prevention packages like ITN and RS for expanding hotspots. So we acknowledge our university, Amara Public Health Institute, and Regional Health Bureau for data sharing. And I thank you for your attention. Thank you very much.
Thank you, Kasama.
Good morning, everyone. So it is my pleasure to be here to present our study findings My presentations will focus on research findings from the effects of early intervention that is grounded on theory of learned behaviors and reducing both the behavioral intention as well as the actual practice behaviors in the same component. So, as to here is the presentation outline from the background to the acknowledgement. As to the background, so chat is remains a major public health problems in East Africa, including Ethiopia, because it is users are most associated with the development of impaired cognitive functions, anxiety, and other mental health problems, including cardiovascular disease. So, research findings from Ethiopia it indicates that the prevalence of current chat use ranges from 8.4 to 42.3%. So the lifetime prevalence is more than in some areas it is more than 50%. So the theory of planned behavior poses that is the actual behaviors are determined by the intention, which is influenced by the three theory of planned behavior constructs, namely the attitude, subjective norms, as well as the perceived behavioral controls. So, despite the high prevalence of current tattoos behaviors among secondary students, so evidences are lacked that theory-driven and peer-led interventions are lacked in Ethiopia. So, by integrating the concepts of theory of planned behavior with early education approaches may result in a comprehensive approach to reduce child intention by targeting simultaneously the cognitive as well as the direct and indirect constructs of the theory of planned behaviors. So as to the theoretical framework of the study, it indicates that is well-designed peer-led interventions will influence the knowledge and risk perception of the students and simultaneously addresses both the direct and indirect constructs of the theory of planned behaviors. This together with results in reductions of behavior orientation as well as current task behaviors. Okay. As to the hypothesis and the objectives, we hypothesize that the hypothesis hypothesize that the peer-led theory of planned behaviors has no effect on both the behavior orientation set as well as the actual task behaviors. As to the alternative hypothesis, we hypothesize that a theory of planned uh, behaviors will result in both behavioral intention and as well as stats with behaviors. As to the study objectives, the study explores on the effects of a period educational intervention grounded in the theory of planned behaviors in reductions of both the behavioral intention as well as actual chatting behaviors. As to the method and materials, so this study was conducted in Dasein and Kombucha in Amharians. So the Dasein is also it's 401 kilometers away from Addis Ababa with a total of 7,824 students. Okay, the kombucha is also that, and as to the study design, we applied the quasi-experimental with pre and post test design to assess the effects of this study interventions. As to the source population, so all students that enrolled in public secondary schools in the Kodas and Kombolcha were the source population for this study, and all students attending the secondary schools during the study period was the the study populations. So students enrolled in secondary school students from grades 9 up to 12, including the study. As to the sampling and sample size, so a total of 1,496 students were involved in this situation with 748 students in the intervention and controls harvest. As to the sampling technique with a stratified cluster sampling approaches, so schools were treated as a cluster and randomly selected as intervention and control groups, and within each selected groups, the schools, so grades were selected using proportional allocation to size, and then intact classes were then randomly selected from the chosen grades. So all eligible students registered in the selected cluster were included in the baseline assessment as well as interventions. So regarding the descriptions of the interventions, the peer scored intervention was a peer-led school-based educational programs that is explicitly grounded in theory of planned behaviors, both aimed at prevention of initiation as well as cessations of chat use. As to the structure and delivery, it is implemented over 4 weeks, 1 hour sessions that is conducted during the regular school hours and facilitated by trained educators, that is 2 per intervention classes and supervised by the research team as well as school staff. So the sessions are targeted the cognitive as well as the theory of both the direct and indirect constructs of the theory of planned behaviors. So the general aims of the intervention is to promote negative attitude to evaluations of chat ways and strengthen their perception that chat uses social discouraged by peers and other significant others, and encourage their perceived behavioral control, efficacy and resistance to peer educations, and improve knowledge and risk perception, finally reducing both behavioral intention as well as the actual chat use behavior. This is a field for changing the module summary, which is already explained the previous one, and this is on about the general descriptions. So we selected 2 schools for the interventions and 2 schools for the control groups. So the intervention groups were received 4 structured sessions for the period of 1 month, and it is followed for 3 months. Finally, a total of 784 students for both arms were included in the final analysis. This, sorry. As to the data quality assurance, training was conducted and following the adherence to the intervention protocols. Okay, so as to the analysis, the general estimated questions models was fit with group time interactions to examine the effect of the intervention effects on the outcome by adjusting for the baseline covariates. Okay, so both the informed and reference consent and assent alongside with guardian or parents as ways obtained. As to the results, here is a result. As you saw, most of the socio-demographic characteristics are that's comparable as baselines. So this confirming balanced demographic characteristic is the intervention control group, but there is some variability in the parental educational status and parent education status discussion with parents about. This is adjusted during the analysis. We adjusted this baseline differences using GE models. Okay.
You do have 4 minutes.
Okay. So these are when you see this one is the interventions, the comparisons. So the knowledge there is after the interventions, the students get significant knowledge improvements. As you see, but in the control groups, there is a remained unchanged. As to the attitude, the students are developed negative attitude towards chat with in the intervention groups, whereas in the control groups that is the same. As to the perceived behavioral controls, the students in the intervention groups developed their self-efficacy and resisting influences from the significant others, and in the control groups there remains the same. Okay. So into the primary outcomes that the behavioral extension and current use. So the students are developed negative their behavioral attention, the interval significantly reduced participants behavioral attention to chat use, and while there's no significant change so far. Okay, in the current chat use, the prevalence of current chat use in the intervention group decreased markedly around half it. Okay, whereas the control groups are remained unchanged. As to the final model, that is a parameter estimate from the general estimation equation, showed that this is the finding case as intervention significantly increased the knowledge about chat and its perception, and as well as their perceived behavioral control and self-efficacy in resisting peer pressure from significant others. And this aligns with the previous study that which demonstrates that theory behavior-based intervention, enhance awareness and self-efficacy, and reduce favorable attitude towards the substances. So both the direct and indirect measures changed in the hypothesized directions that are reinforcing that the intervention shifted both overall evaluation and specific belief that underpin intervention and behaviors. As to the conclusions, a brief and low-cost peer-led educational program that is grounded in the theory of planned behavior provides short-term reduction in child education and current use, as well as cognitive and psychosocial discernment of such use among secondary students. This is a pragmatic prevention approach that merits pilot scale up with long follow-up and economic evaluations. As to the recommendation for policy and program planners, so scaling up theory of plan-based peer-led intervention within the national adolescent substance use preventions. As to the school and educators, so it is implement structured peer education that is integrated with chat awareness and educational skills are recommended for researchers. So it is evaluating the long-term sustainability that adapts intervention to diverse setting and leverage digital platform to enhance reach on the farm. After the government and NGO in low resource setting, I think that is scale up this peer-led school-based interventions as an evidence-based cost-effective strategy in prevention of substance use behavior. It is a reference as to the acknowledgement. So I acknowledge the data collectors and peer educators, supervisors, local authority, then participants and AFI for arranging these scientific forums. And finally, my detection goes to my PhD mentors, Dr. Shatu Gurma. So tragically, who listed in the previous 3 days. And thank you very much.
All right, I think thank you, the 3 presenters. It come with very important topics that needs considered for further intervention. One topic was malaria, the other was on education, getting education to prevent the magnitude and impact of chat users at school children. And the first is on neonate health prediction. So the 3 presentations were very important, and we hope they will be እንትን ልስጥና ቶሎ ሰዓታችንን ለመጠቀም ጥያቄ ለእነሱ ግብአት የሚሆን ለቤቱ ደግሞ ተምሮበት የሚሄድ ይህን እንዴት ሰራችሁት ያልገባል ሊሆን ይችላል ሜተድ ዘን የእናንተ ፋይናል ሪኮሜንዴሽናችሁ ምንድን ነው? እነዚህም እንዴት እንጠቀማቸው ቃል እኔ ኮርስ አራይት ግሩም አንድ ቁጥር ሌላ አንድ ቁጥር ልስጣችሁና ድሩን ተጠቀሙበት ይናገር 2 የለም አራድል እሺ እስቲ ራስን አስተዋውቅ እስቲ አቡካለ ተነስና አንዴ ይዩ አዲስ እንግዳ ስለሆነ ለንደን ስኩል ኦፍ ሃይጂን ያለ የማታ ዩኒቨርሲቲ ስታፍ ነው አጋጣሚ ዛሬ እዚህ ተገኝቷልና በጣም ትልቅ ሰው ናቸው 3 ልስጥ እሺ የሶስታችሁን እንስማና አልገባኝ የሚል ካለ ደግሞ በኋላ እንጨምርበታለን። ስለዚህ ጥያቄያችሁን ለእንትና እያላችሁ ትሬክ ግሩም እሺ ፕሮስ
malaria prevalence or the multifaceted እንትን አመን ፕሬግናንት ምን ነውና ኤምአይፒ የሚለው ጋር ትንሽ እንትን አይደለም ወይ ማለት የፕላሴንታል ማላሪያን መካት ነበረበት ኮንጀኒታል ማላሪያ መንካት ነበረበት እና እነዚህ ባልተነኩበት ሁኔታ ማላሪያን ፕሬግናንሲ ብሎ ማለቱ ታይትሉና ኮንቴንቱ ምናልባት እንግዲህ የፒኤችዲ ስራ ስለሆነ የዚህ እነዚህ ፓርቶች በሌላ ፔፐር የሚመጡ ከሆነ አይዶኖ ግን አሁን ለቀረበው ግን አመን ፕሬግናንት ሜል ነው እንጂ ማላሪያን ፕሬግናንሲ ነው ተቻለ አረገኝና
ስኮፕ ማምለጫውንም እያሳየ ሆኖ በዚህ አጋጣሚ ታንክ ዩ ነገር
ሶስታችንን ማመሰግናለሁ። የመጀመሪያው ጥያቄ ፎር ዘላለም ፎሎ አፕ ስተዲ ነው የተጠቀማችሁት። ፎር ፎሎ አፕ ስተዲ የተጠቀማችሁት ደግሞ ሎጂስቲክ ሪግሬሽን ነው ፎር ሞዴል ፊትነስ ግን አፕሮፕሪየት ታይም ቫሪዬሽን የሚያሳየን ሰርቫይቫል ነው ዊዝ ዮር ዲዛይን የተጠቀማችሁበት ጊዜ ፎሎ ያደረጋችሁትን ክሊር ያላስቀመጣችሁትን ክሊር ልታስቀምጡት ጥሩ ነው። ፕላስ ቱ ዛት ፖስትሞርtem ደግሞ ፎር ካሊብሬሽን ተጠቅማችኋል። አሁን አዘንዶ ዘዴ ባለሙያዎች የሚጠቀሙበት ነው እና ካሊብሬሽን የምንለው እሱ ደግሞ በትክክል ኢንዲኬት አይደለም። ኢንስቴድ ኢንተርሴክሽን ኦር አዘር ስሎፖችን አሳይቶ ክሊርሊ ባለሙያው ወይም ደግሞ ፊዚሻን እንዲጠቀምበት ሪኮመንድ ማድረግ ነው እንጂ የሚሻለው ያኛው ክሊርሊ ልዩነቱን አያሳየንም እና እሱን እንዴት አያችሁ? ሌላው ሪኮመንዴሽን የሚሰራ አይነት እንትን አስቀምጣችኋል። አሁን የሰራችሁት we are in the limited resource country ይሄ የሰራችሁትን ተቀብለን አፕላይ ማድረግ ብትፈልግ ኢንጂነሮች እነማን ናቸው? ክሊርሊ ዲስክራይብ አላደረጋችሁም። ኤክስፔክትድ በጀት ለምሳሌ የእናንተ እንትን ሆስፒታል ወይም ጤና ጣቢያዎች አፕላይ ማድረግ ቢፈልግ ከአንድ ተቋም ላይ ምን ያህል በጀት ያስፈልገዋል የሚለውን ክሊር ልታስቀምጡት የሚል እንትን አለኝ። ፎር ካሶማት ኖርማሊ ቻይልድ አውትካም ብለህ ያስቀምጥካቸው ስኖት ቻይልድ አውትካም ኢንትሮዳክሽን ላይ አይተህ ከሆነ አቦርሽን ምናምን ይላል እና ቻይልድ አውትካም ይላል። እሱን ክሊርሊ ብታየው ዶክመንት ላይ እዚያ ኤሪያ ላይ የተወሰነ ኤክስፐርት ላይ እንትኑ ላይ እሱም ክሊርሊ ነው ቻይልድ አውትካም ያልሆነ ግን ፕሬግናንሲ አውትካም ያካል። ቴምፖራል ስፓሾ ቴምፖራል ኤንድ ሶስት ሰርተሃል ፍሮም ዘ ትሪ ፎር ፖሊሲ ሜከርስ ኮንክሪት የሆነ ሪኮመንዴሽን የሚሰጠው ከሶስቱ የትኛው ነው? ፕሬግናንሲ ላይ በእኛ ሀገር ኮንቴክስት ለፖሊሲ ሜከሮች ክሊር የሆነ ኤቪደንስ ለአንተ አሳማኝ የሰጠህ ቴምፖራል ስፓሾ ቴምፖራል ኤንድ ስፓሻል የትኛው ነው? ክሊርሊ ሶስቱም ናቸው ወይስ ከሶስቱ አንዱ የተለየ ስትረስ ሰጥተዋል? እሱ ሪኮሜንዴሽን የትኛው ታስቀምጠው ጥሩ ነው። የመጨረሻው የወር ሞዴል አለ አንተ የተጠቀምክበት
የላይት ባረክ የመጨረሻው ስትል ለካሶማር ይመስላል እዚህ
አንተ የተጠቀምክበት ሞዴል አለ። ሩትን ደግሞ ለሳብስታንስ አቢዩዝ የኛ ሀገር ኮንቴክስት እንጠቀምበታለን። ሶ ዋት ኢዝ ዘ ጋፕ? አንተ ፊልም የምታደርገው የኛ ሀገር ሞዴል ኦልሬዲ ኢምፕሊመንት ምን አይሆን ባይታወቅም ግን አለ ሴት የተደረገ። ስለዚህ የዚያን ጋፕ ምን ነበረ? አንተ የምትሞላው ምንድን ነው? እሱን ክሊር ልታስቀምጠው ጥሩ ነው። ሌላው ወደፊት ምን አስባል? እኔ ምን አሰብኩኝ ኢንተርቬንሽናል ስሪ አርም ብታደርገው በተለይ ኮሚኒቲ ኢንጌጅመንት ቢጨመርበት ይህ ክሪቲካል ነው ኤኒዌር ያለ ነው እና ጫችን ፕራክቲካል የሆነ ኤቪደንስ ማግኘት እንችላለን እና ስሪ አርም አድርጎ ከኮሚኒቲው ካሉ ፓርቲዎች ጨምሮ ይሰራ። ሰርታችሁት ከሆነስ ይህን እንዴት አይነት ላይ ታገኛችሁ የሚል ካለኝ አመሰግናለሁ።
ካሳሁን ቴንክ ዩ ናይስ ፕሬዘንቴሽን። የኔ ጥያቄም ከዛ ይገናኛል። ለምሳሌ እናቶች ላይ ያየኸውን ዳታ ፕሬዘንት ስታደርግ ኢንተረፕትድ ይሄ ታይም ሲሪስ አናሊሲሱ ላይ የማላሪያ ፕሪቫለንስ እና የቴምፕሬቸር አብረት ለማድረግ ሞክራል። ለምሳሌ ማላሪያ ፒክ ሲሆን ቴምፕሬቸር ማወቅ ፒክ የሆነ እሱን ዳታ ቪዥዋላይዜሽን ላይ ብታስበው የሬንፎሉንም የቴምፕሬቸሩንም ሁለቱም ሪሌት መሆናቸውን በግራፍ ለማሳየት ይቻላል ይመስላል። እና ሜይቢ እንደ ወደፊት ስፓሾ ቴምፖራል ስለሰራ በጣም ሃይ ሪስክ ኤሪያዎች ካሉ እንደ ኢንተርቬንሽን ሌሎች ሀገሮች የተገቡት IPTP pregnant women ላይ do you think it's a potential intervention in the future? በተለይ አሁን ማላሪያ ሲደርስ በጣም ፒክ እየሆነ ስለመጣ የተወሰኑ ሴሌክትድ ኤሪያ ላይ እሱ እንደ ኢንተርቬንሽን ሪከመንድ የመደረግ ፖይንት ላይ ደርሰናል። በዛ ላይ ደግሞ ቫክሲን ኢምፕሊመንት አድርገናል አሁን በሀገሪቱ ላይ እና do you think these areas they require vaccine የማላሪያ ቫክሲን በተለይ ፕሬግናንት ውመን ላይ የሚያሳዩት ፋይንዲንጎች ምንድን ነው? እናቲቱ ቫክሲኔትድ ከሆነች ለልጇም እንደሚያልፍ አዲስ የወጡ መረጃዎች ይታያሉ እና እሱን ኮንሲደር ብታደርጉ ይመስላል ከፋይንዲንግ ሀብታም ነው መሰለኝ ማይግሬሽን ላይ አንድ ጥያቄ ለማየት እንትን just for curiosity ጫት እንትን ላይ በተለይ ኮምቦልቻና ደሴ በኤጅ ዲስትሪቢዩሽን ለማየት ሞክረናል። አንላይክ አደር ሲቲስ እዛ አካባቢ ስኩል ሌቭል 8th ግሬድ ጀምሮ ኤክስትሪምሊ ሃይ ነው ሳብስታንስ ዩዝ ከጫት ጋር እንደዚሁ ደግሞ አብሮ ሳብስታንስ ዩዝ ማለት እሱን ለማየት ሞክረናል። ሃይ ስኩል ላይ መስራት ጥሩ ነው፣ ግን ደግሞ ፖፑሌሽኑ ሰፋ ብሎ አውት ኦፍ ስኩል ያለው ፖፑሌሽን ኮምፔር ብታደርገው ምን ያህል ነው የሚለው እና እንደ ሪቪውስ ሌላ ቦታ ካለው ጋር ኮምፔር የማድረግ ሀሳብ አለ?
ታንክ ዩ ጥሩ ጥያቄዎች ተነስተዋል። ምናልባት ለኢንቫይሮንመንት የተወሰነ ጨምረው ሜቢ ኢንፎርሜሽን ከረዳችሁ ጀስት ዩር ፕላን ኢዝ ቱ ብሪንግ ቢሄቪየራል ቼንጅ that will take a longer time, yes, since it is behavior. So how was the intervention period appropriate to bring just visual, because you said that there is a reduction in chat users, yeah, so how it was visible, or how was the intervention period adequate just to bring behavioral change? That's my question. And based on your observation, Sani was also asking you about the age category and grade, chat users versus grade or age category. Just have you approach with that to see the burden is increasing or decreasing, which are the most users and which are the most acceptors for your intervention, either the lower grades or high grades, because they do matter. So please try to give your explanation. I will start with Kasama. What is it?
Okay, thank you very much for all the comments and questions are very good for me, and we will consider for the revision of this manuscript. Actually, as the groom side, this is one of the PhD manuscripts, and it's focused on malaria pregnancy. Malaria pregnancy and malaria pregnant women are somehow confusing term. As a program, as a WHO, malaria pregnancy is a common term. That means anything that's associated with malaria and pregnancy can be called malaria pregnancy. Either malaria pregnant women, either malaria infection with the mother during her pregnancy time. So all the general term, the broad term is malaria pregnancy. So I used this term because it's a well-known term for a program, a well-known term for WHO. WHO has a definition. So what lacks in this study, it was better if I defined what does mean malaria pregnancy in the context of this paper. As groom side, malaria pregnancy is broad. It includes placental malaria, the different things that can be included in the malaria pregnancy. But I will include the operational definition, what does mean malaria pregnancy in the context of this study. So that's a good comment. And the other comment is from Inaga. Yes, one of my concrete recommendation from this study that both the space and the time element. As you have seen from the presentation, malaria in pregnancy is different from time to time, especially the recent time is becoming increasing. The incidence is increasing in the becoming time, like after 2022. So it tells us
something that the malaria is shifting. And our focus was from the general population perspective, but the pregnant women perspective is something that was neglected. So I bring this agenda to the attention for programmer, to the policy, and for healthcare providers that we have to focus the pregnant women as malaria is one of the risk for her and for neonate. And the mixing of the child outcome, yeah, yes, I will correct that. That was the pregnant outcome, not child outcome. I will correct from the document. So thank you for that comment. Dr. Sani, thank you very much for having this conference. I know you are one of the experts on malaria, especially on vaccine and IPTP. Yes, I will recommend strongly IPTP should be implemented in Ethiopia because the malaria pregnancy becoming a major issue in Ethiopia. By the way, my PhD title is across the Ethiopia. So this paper only is on Amara region because I don't have data, the surveillance data at national level. So that's why I included only the Amara region for this statistical analysis. But the other part of my scripts are from the Ethiopian context, malaria service availability, readiness, and qualitative quantitative barriers. So from all the findings that indicate that this IPTP should be implemented in Ethiopia because in Ethiopia malaria is targeted for elimination from the general population, leave alone from the pregnant women, but the story is different. So you remember 9.2 was the incidence for malaria pregnancy in this region from the entire 7 years. And when you see the recent time becoming increasing, when you see the projection even for the next year, it will again increasing. So it tells us we have to do something different other than this ITN and Latin. So we have to integrate the malaria service with ANC service. We lack service integration. Our policy do not recommend the service integration between the ANC and the malaria. So we have to recommend that. Again, we have to recommend IPTP should be implemented.
Thank you, Zalalam. Thank you, Dr. Okay, thank you so much, Dr. Inagar, for your question regarding our model. Yeah, we use a follow-up study, a prospective follow-up study. And then we use the logistic regression. Yes, it could have been possible also to be using the survival analysis, using survival analysis. But our interest is this follow-up. The follow-up is just to find the outcome, meaning that once the patients or the neonates admitted and then diagnosed with NEC, then the follow-up, the one that we anticipate in the future is the occurrence, the outcome, meaning we are not interested that much in the time aspect, the effect of time. Otherwise, yes, it's also possible. The model can be survival analysis also can apply, but we use the usual logistic regression. The other issue regarding the model fitness, the Hosmer-Lemeshow p-value, of course, this is an additional, but the calibration plot is the best, better, and the intercepts were also used. Physicians may not use Hosmer-Lemeshow, even the intercept also, just to show how our model are fit, our model is fit, how our model is good. Otherwise, physicians or implementers finally use the nomogram, meaning that the final tool. This is just to show how our model is fit. And then the final nomogram is to show that it's good. Otherwise, they can't use, definitely, they don't go to the interpretation of the p-value. The end users, of course, usually the healthcare providers. We develop the tool, and then this tool used for stratification of the patient, the neonates. So it is the physicians that's going to use, the users are healthcare providers. Regarding our meaning the study to be conducted, again, external validation is required usually. Once you conduct a study in clinical research, it has to be validated externally, which is this is recommended. So that's why we recommend it to be conducted. Our sample is a bit smaller. This is for a master thesis, 251. I agree that this is very small. It would have been multi-center, bigger data can generate a better result. So our suggestion is to be externally validated. Then finally, after external validation, that is this tool may be implemented. That's why we recommended external validation should be done. And again, regarding the implementation, the budget that required if to be implemented, of course, we didn't go through this process, meaning at this moment, I can't say that it requires this much budget to be implemented. I think this requires further investigation. So thank you so much for your insight.
Thank you, Zalalam.
Okay. Okay, thank you very much for questions, and I will accept the comments as comment, and I will certain to some of the questions. Okay. So the first question is why choose the theory of plant behavior instead of other behavior change models? So in this case, there are a number of behavior change models, including physical model and other social cognitive and others models. But the theory of plant behavior was selected because chat use among adolescents is strongly influenced by the social norms, perceived control, and intentions. These are all core constructs of the theory of planned behaviors. Yes. So the model provides clear causal pathways and that are suitable for structural fixations, and as well as the theory of planned behavior-based features, the decision-making pattern of adult and youth substance in this context. Because of this, the theory of planned behavior is best fitted for this research topic. Okay. So the second question is regarding community engagement, and I think this intervention is at PhD papers and mainly focused on school settings, but we didn't directly involve community in these interventions. But we include some of variables from the community, parental components, especially substance use behaviors. And in the recommendation parts, we recommended athletics researcher to include community level engagement in these interventions. The other one is are you assessed other substance like alcohol and test? This intervention is targeted three outcome variables, including childhood behaviors and alcohol and tobacco preventions. So the interventions are more effective in addressing the three outcome variables. Okay. The other one is the intervention regarding the intervention period. I think the 3 months intervention period is a short term effect. It doesn't indicate that the sustainability of the effective intervention behind 3 months. As to we indicate the limitation factors, and we recommended as a researcher to extend the observation for more than 6 up to 12 months to assess the sustainability of these interventions. And the other one is did you assess churches versus some level of an especially age and lower grade levels? So we assessed, we stratified the analysis based on age and also grade levels. So regarding grade levels, the lower grades are more acceptance of the information rather than higher levels. And also students in the early adolescent ages, that is 50 up to 90% are previously they are more intended to use the outcome that special charters, but after the interventions, they are more reduced their behavioralization as well as charges behaviors.
Thank you very much. I think they tried to give possible explanations for the questions and comments raised from the audience. So let us thank them for their time. Thank you.
ምናልባት ሻይ ስለሌለ እንቀጥል ወይስ አልፈን እንመለስ? አሁን የእረፍት ሰዓት ነው። 3 ፕሬዘንተሮች አሉ። ዶክተር አውራሪስ፣ ስመኝ ሰንደቅ፣ ስመኝ ነኝ። እሺ፣ አስማማው ማለት
አስማማው ደክሟችኋል?
Connection successfully. ያንንም ሪፍሬሽ አድርገው ቪዲዮ ኮል ኤንድ ሚቲንግ እንደ አዲስ እያለ ኒው ሚቲንግ እያለ እና ስታርት ኢንስታንት ሚቲንግ ልማት አስከ ሚሊዮን አይደለም። እንደገና ነው አንተ ነው ወይ ጆይን ማለት ነበረበት። ጆይን ማለት ደግሞ እንደገና ፖድካስት ምናምን ለማለት ኤጀንት ነው ኮኔክሽን ያ ሰራልን ነው መሰለኝ። ኧረ እስኪ ወስና የኔ ነው የገባል። የኔ ነው የገባል ግን ችግር የለውም ይሰራል። እኮ እንትን እንደገናችሁ ፕሬዘንት ላይቭ ስትሪሚንግ የትኛውስ ይቻላል ነው ቢያላል ሪከርድ ምናምን የለም። ያኔ እኮ ይገናኛል። ዙም ሚቲንጉ ጋር ይገናኛል። ዙም ሚቲንጉ ይገናኛል። ኮንትሮል ኬብል እንትን ካለ
ይሄ ደግሞ እንትን ይደረጋል።
እሱን ሳያስተካክልልበት የዛ ችግር የለው የዛ እኮ አለው። በቃ አንድ ስለዚህ ያንን ፕሬዘንት ያለው ማለት ይችላል። ተስተካክሏል። ይችን ሪካርድ እናደርጋታለን።
እስካሁን ሳይቶቹ በአቅራቢያው ሰው ስድስት ሳይት ስለሆነ ስድስት ናቸው። አይ ስድስት ናቸው።
ሎካል ሪከርድ ነው እሱ ላይ
መጀመር እንችላለን። ያው ኮኔክሽን እንትን ብሏል። ያው ባለው እንትን ጀመርና
Okay, welcome back to this session. We continue our session. We will have two presenters. The first presenter is Dr. Abraham Said, entitled with Kabili elimination of trachoma for ocular health, or abbreviated as KUTFO. And the second presenter, so far at hand, is Dr. Samay Sandak. He will present thriving despite attending his postdoc in University of California in the United States, and he was a former dean of the College of Health Science at General University, and he has more than 40 plus publications in general. So he is affiliated to school publications at the Department of Publications. So this is a short profile. Thank you very much for coming. The second presenter is Dr. Samay Sandaku from University of Gondar. He is also a PhD in psychology. He is from the College of Social Science and Humanities College at the Department of Psychology. He is now currently the coordinator of research center at his college, and he's also an associate professor as well, and he has publication more than 15 publications. So this is a short profile of Dr. Samay.
Thank you for coming, Samay. Thank you very much. Now we'll start the first presentation by Dr. Aras. Please have a stage. You have 50 minutes of presentation.
Okay, thank you, Chairman, and good morning all. I'm going just to present the government elimination of trachoma for ocular health. In fact, this is a 3-year which has been conducted in one of the Amara region waradas or district, Marhabete district, which is the highest burden. So we are waiting for the final trial result or impact to know the impact with regional laboratory or APHA lab to test the samples. So these are the presentation outlines. Maybe I may not follow all the procedures with methods, conclusion, and recommendation as well, because it is a huge with a lot of objectives. So I may only just provide the progress of the trial and maybe the baseline and the 12 months gross or crude progress. Otherwise, the final result is coming soon, and I will present it once the final 36 months examination is completed. As a background, annual mass azithromycin distribution is effectively ocular chlamydia trachomitis, and this has been done so far in most countries globally, as it is a WHO recommendation. And however, infection persists despite after a decade of treatment. Yes, of course, more than 10 rounds of treatment have been provided in North Shore, and not only in North Shore, in Amhara region as well. But still, the prevalence in some districts is below 5, and some districts is beyond 30%. And this is, again, it needs research why this is the reason. Maybe we have one research, one project which have been just started this year to know this, why this prevalence is high. But for the sake of this CUT4 trial, more frequent targeted treatment of core group of children responsible for most transmission may offer an alternative strategy. If we provide treatment frequently, then we can reduce the bacteria, we can prevent the transmission so that we can just eliminate trachoma. This is the logic behind this CUT4 trial. So a previous trials found that quarterly azithromycin treatment of children for 1 year significantly reduce the prevalence of chlamydia trachomitis, and this has been also been done in some districts of North Shore, like I think in Saro with Carter Center for Children's once, but 3 times is by far the most effective one, and just we are going to look the results of this CUT4 to escalate. Partners globally are just waiting for the CUT4 trial final result just to escalate or just to implement this to the wider areas of the country. So that these are the objectives. The first one is to determine whether targeting core group 4 times per year is more effective, including MDA, that means, than the current WHO program at achieving elimination after 3 years, just providing the targeted treatment, and to compare different core group strategies would have 4 is the age group, TI group, PCR, and then the comparator WHO. So this is the methods. In fact, the setting is at North Shore, as I have just mentioned, and North Shore is hyper-intermittent FNTI. Community recruitment and eligibility was done with all communities in the study that are eligible in the inclusion, and the cluster randomized trials with one and one fashion, that is 20 cavalets with WHO or community targets, and 60 with age group, 20 with TR, PCR 20. So the whole is the 4R trial. So in short, this shows a clear picture of how it is just the intervention is implemented. The first one is WHO. Then we provide 3 times MDA yearly. Then the second one is core group age, all individuals or children whose age is 1 up to 9 will be provided 3 times per year treatment. That means it is for 3 years. So in total, targeted treatment is provided. Then the third one is core group infections. We talk swabs, and we just look the diagnose the children's for chlamydia, and those who have the infection were given a treatment again, and core group TI also given annual MD plus 3 times targeted treatment. So this is the whole intervention of the 3 years trial. So the field teams masked laboratory and grading, swab, DBS, photograph, masked, and lab and grading personnel blinded. Also, there is also regrading. Photo will be taken during examination, and that is also regraded by individuals based on the pictures that was taken from the children's. And data collection and management, we use home care software with tablets, so that we have just been done all the examination as well as the treatment with that. But unfortunately, due to the security conditions, we agreed with the communities and with those in that district, and we try to use hard copies, and then we implement double data entry with Concur as well. So it is huge, by the way. More than 15,000 data will be collected, and it is double entered, and the discrepancy also managed. So that is the way we manage for the security reasons. Sample size, yeah, the sample size was developed with this assumption. I think you can look with the power as well and provide sensors, and in between there was some instabilities, and we take a gap. But after stabilities, and we take a gap. But after that, we give the exam training, and then examination was conducted. And all the samples, even the samples are more than, I think, 10,000. And all these samples have been just transported from the Marhabite district to Bahar Dar for test. All these three. Unfortunately, the 24 months examination is not conducted here. This is the 3-1. So the baseline, the first year, second year, and the third year. So the 24 months examination is not conducted, but all the others have been just implemented or conducted. This is the MDA and targeted treatment timeline. The first targeted treatment, then MDA, then the second targeted treatment, and so on. That is the nice treatments. We plan 4 census, but we conduct 3. The 24 exam is not, the 24 months census exam is not conducted, that is why. But it is not, it is good to look the progress, but what we want is to look the final prevalence of TF or ocular chlamydia at 36 months. That is why we conduct the 36 months and the 12 months. So now I will show the 12 months comparison with the baseline. MDA, we just conducted all MDA, 3 MDA, and 9 times targeted treatment. We plan just to conduct 4 times, including the baseline, but the 12 months is not just yet done. The 24 months is not yet done, and 36 months is being conducted now at APHA. So we had 3, and maybe one, the 36 months is not completed. That was why it has been there. Side 2. Just comparing baseline characteristics at baseline, if you see the TF prevalence, it is 46, and result dissemination will be conducted as a country, and probably maybe nationwide. In fact, these results have been just presented in different WHO conferences globally, and maybe just will disseminate it with WHO for further scale up. These are the acknowledgements for all institutions, including the Ethiopia, IPHI, Harvard University, UCSF, Carter, ITI, and even the districts that were working. Thank you so much.
ኦፖስ የሚለውን ናቸው ኦቤሱን ሸር አድርገው ማለት ነው። ይችን ኢሜጇን አሁን የከፋው ከዛ ተባል ኦኬ እሱ ላይ እሱ ፕሬዘንቴሽን ፉል አላደረገው
እንደምን አደራችሁ። Okay, thank you very much. This is a piece of work titled Thriving Despite Adversities, Building Resilience of Children Through School-Based Mental Health Intervention in War Situations. This is a work that is done at Gondor City, specifically. I will go through this outline, background, their rationales for treating recommendations, and finally about the acknowledgements. When it comes to the background, as we know, period of childhood is very critical since it is a foundation for erecting or founding the architectural or formative stage. So this is a stage that we expect fast changes in multifaceted or multi-directional developmental domains of human nature, and we can consider this period as an opportunity. Even if children need safe and comfort during this period, there are factors which are related with natural or maybe man-made factors or adversities affect their development, and that disturbs the public order of their development, and that affects their normal development in general. And one of the factors that we are facing today is the conflict and war situation that we are recent data, almost recent data, that is the EU members, member countries, around 11.2 million or 13% of children experience mental health problem. And when we come to the sub-Saharan Africa, 1 in every 7 children experience the problem of mental health. And when we come to the Ethiopia, a systematic review that is done by Al-Kidan and others, it's around 26.5% of children are experiencing mental health problem due to different factors. So if this is the case, schools can have very important roles in managing the problem, in helping children to capacitate or to cope up from the problem. So schools have very important or ideal places to easily avail the mental health intervention or services that can encompass the promotion and the prevention packages that can build the resilience of children in general. So according to the data that is taken from UNICEF, a $1 investment in terms of saving how much we invest yearly is how much very profitable, profiting us to save the cost of investing later after the experience. So for every $1 investment on school-based mental health resilience programs, we can produce or we can have a return of 21.5% or $21.5 return if we invest on children at early stage. So, school-based mental health promotion and prevention improves psychological well-being of children, and that also reduces the prolonged exposure. That can help them to have a capacity to cope or to resist the problem with regard to conflicts, war, and forced displacement related crisis. So they are been to support adolescents there. But if you see or if you visit the primary school and the early childhood period at the preschool, there are no any professional there in order to support children who have different mental health problems. So that is one of the factors. There is neglection, and there is no visible services that is given by teachers or any other para counselors or other individuals or personnel there. And there are also limited empirical evidence that shows how much the child mental health intervention at the preschool, at the primary school level, helps them to enhance their resilience capability. So we are triggered to examine the status of mental health issues, particularly focus on intervening on the resilience side of children by providing soft skill training, including packages that I will show you later on. Study area, Gondar City, primary schools, since these schools can be important to reach larger number of students at a time, and that may overcome the barriers of location, time, and stigma, because since we consider them as groups, and we have a design. We use the design that is cluster randomized control trial design, and we had 3 phases: baseline, intervention, and post intervention data collection, and we drafted a package of delivering training on focus on the self-discovery, mindset development, self-efficacy, emotion regulation, problem solving, and social skills. These are the major components of the package for the training, and we are trying to base on the strengths-based approach in order to help them to know about I have, I am, and I can. The I have refers the external resources around children to assess, to know, to be aware about the external resources, including the resources from the teachers, resources from the parents, and other potential, their resource within, so that they can develop a kind of or a sense of I can. That is a resilience. So that was our intention, and we focus on the strengths-based approach of helping children. And we consider 205 children selected from primary schools of private and government schools. 4 schools were considered. We used the questionnaire having skills to measure the mental health. We use the DAS-21 and child and youth resilience measure for measuring the resilience change, and we use a disc intervention, and we unwell due to the presence of different conflicts because they see of the war. So they are at the stage of struggling. That helps. Oh, sorry. So if we intervene, okay, if we intervene, we can help, we can support them to cope and push them to be well, mentally well in their, so that they can function well in their day-to-day school activities. So having when it comes to the findings, After the intervention, we have found that the experimental group scored statistically significant higher mean score than the control group, and this is the table that shows the difference before and after the experiment, the intervention, the package implementation. That is, there is the pre-intervention score for the experimental and for the control group, and post-intervention score again for the experimental and for the control group. And we have found that the difference was statistical difference, I mean significant, but it was not very, very big. The test score was not that much high, even if there is a significant difference. And we try to see whether there is gender difference and school type difference in terms of the change in because of our intervention on the resilience scale score. There is no statistically significant gender difference in school type. That means both males and females, and in both school packages, there is no difference in terms of this school type and gender. When it comes to the conclusion and recommendations, mindset development, self-efficacy, emotion regulation, problem solving, and social skills significantly increase the resilience of children. So we recommend that professionals, education officers or officials, organizations working on children should design strategies to strengthen school-based intervention aiming at enhancing their children's resilience. And schools should also allocate time for psychological makeup, either by integrating into the regular class schedule, or maybe another schedule maybe that may be provided at the weekend period, that can help children to boost their second weekend period, that can help children to boost their psychological.
Example, displacement and use of caregivers. Thank you.
Okay, thank you both presenters for your nice and scientific presentation. And my question is goes to I'm Sagar from the Brahma Press University. And my question is goes to Dr. Aurais. I know very well, Dr. Aurais, you are the most committed and genius individual, and I was your student at Development Science College, and I'm happy to see you here. The first question is, what do you think about the reason why the prevalence of trachoma is still high despite 10 rounds of azithromycin treatment? Because we are waiting, trachoma was eliminated, and I think the campaign was phased out because without that, trachoma was eliminated. And the other one is, how did you control the reinfection or the cross contamination between the individuals after you start a treatment or care? How do you control the reinfection? Because in our community, people can get together in different ceremonial gathering, and this gathering will create an opportunity to transfer the trachoma infection. And the other one is, how does the community perception to receive that azithromycin? Because it was a very challenging campaign. I participated during that azithromycin treatment campaign because perception of communities was not good regarding that azithromycin campaign, even though the azithromycin treatment was given in yearly basis. So how does the community's perception in your trial? Thank you.
All right. Thank you for presenters. I mean, both presenters. And I have some comments to summarize.
Maybe for research and community science engagement at Bahar University. So just as a cultural effort, introduce us for newcomers and us.
Thank you. Yeah, my first question is just what is resilience in terms of school children? Resilience in and why you worry about or why you choose resilience rather than other interventions especially at school children. And what was the status of mental health among school children? If you just determine it. And the second is, my last comment is on your recommendation. Yeah, it's well known that just research is just for better recommendation to be implemented. Yeah. So your first recommendation says partners, school, and other concerned office should design strategies to bring resilience. Because it's a PhD work and you are a researcher, so you are expected to recommend implementable, targeted, and specific recommendation for implementation. Just if you give this recommendation to the health office, the city, or the regional health bureau, they will ask you directly what are those strategies that I am going to implement. So what are those strategies? Because recommendation should be clear, specific, and targeted. Thank you.
Thank you.
Thank you. Mohammed from the Carter Center. And my question is specifically for Dr. Awad. I really appreciate very interesting work that did. Actually, I also know your work earlier as a professional worker on that area. So maybe one clarification question and that programmatic impact of this work I orient when this project will go next. What is next for this project, and what specifically are we going to do after this project? What do you expect from that?
Okay.
Is that to be maybe scaled up to the region or any other events that could be incorporated into the program existing program? Thank you.
Thank you. Thank you. We will come back. Okay.
Or not after this intervention. And I can say that the prevalence of trachoma have been just reduced or decreased with 15%, 1-5, after 12 years or after 1 year. But we are not sure how much it is decreased at 24 months because we didn't conduct the 12 months. And we are hoping that it will be just below 10% or maybe below 5%. But we are not sure as the result is not just processed and conducted. And I can say that just we will assess some questions and the grading is there, but the grading and so on are not the exact or the primary outcome. So I think it may not be just feasible to say some figures without knowing exactly what the PCR result is, but we are expecting that. And there is also internal comparison. Is it the age-based or the PCR-based or TI-based, or which one to have a more reduction is also internal comparison. So yes, of course, providing with age as a full visible or may decrease, but how cost it is, the cost effective, and even the implementation and the feasibility is also a question. So of course, we had a guideline to provide. So yeah, the intervention is good, but we have to look which one is. That is age-based, I think, but we have the three comparators as well, the infection and the TI as well. So we look that one, and we are not sure whether it is exactly whether it eliminates or not until we look the final result, the 36 months result. That is my suggestion. And for the next question, I think I'm happy and proud just to look my student here. And I'm also thinking that I'm becoming old when I look my student here. And yeah, of course, what is the reason to be prevalent despite 10 years of treatments? That is also correct. That is the question behind. And maybe there is one research that have been just conducted, and the one with the university. So we are going to look at comparative cross-sectional with those two districts having high prevalence and those two districts having low prevalence, despite the same 10 years intervention. And maybe exactly that question that research will address, and we are working on that. Maybe next year we'll have the result for that, and we'll just respond specifically for this. But there are certain things still, maybe from the antibiotic treatment or the hygiene, facial cleanness, and so on and so on. But also treatments adherence. I can say that during MDA provision, we agreed with health extension workers and with all individuals working on MDA to report what they have done. There is also a question. If the prevalence, or if the coverage is less than 90 or 85 or something, they may say that you have to repeat it again, you have to work, and when they become just tired, they may fix some numbers. And surprisingly, our achievement for every day is 81, 82, 80, 83, like that. Not done MDA with 90% coverage, and the real picture is there. But we have to look what is the reason for having low prevalence, low coverage in MDA provision, and the quality as well. Reinfection, yes, but we cluster those with WHO targeted or the WHO intervention, the comparator and others, with the districts which is far from the others. So reinfection from WHO and others is not possibly happening, but it may be a limitation. So geographically, in the cavalries are allocated based on that, and they are by far more remote than the others. But I can say that reinfection is a reason, and we have to work on that districts as well. Merhavite is the highest prevalence is there. Middawaramo, I think 29 or 28% is there, adjacent to that. And Lemi or Insaro, 30, 31 or 30 about that is adjacent to that. And Menzikayagar or adjacent to that. And the other one is Jiru is also the highest prevalence. All the four districts around Merhavitis are higher in prevalence. So after looking what is the reason to be high despite 10 years of intervention, we are going to implement a specific problem-based intervention by Development University on these districts. Otherwise, they will meet on market or wedding and so on and so on. And just intervening specifically in one district may not alleviate because it cannot transmit from one to others. What's next? And maybe community perceptions to take the azithromycin, I think it's very high, and the adherence is very high. So we work on that. There is no force. They understand. Religious leaders and others are working there. And maybe we'll have one proposals, which you know as well, Mohammed, fact study is there. Fact means feasibility assessment and economic perception as well. So we are going to ask the Woreda leaders, health extension workers, and even health center heads, including the regionals, and those partners even involved in that, on that intervention, starting from Minister of Health, how feasible it is to escalate to others. Because the payment, everything, the support, the vehicles, and so on is covered here. A lot of money, I can say. So what if it is escalated? We have to ask these things. So noticing these things, we are conducting feasibility. So how feasibility is and acceptability. Yes, of course, the community accepts these treatments, but how much it is going to others. And the other thing is cost effectiveness is also added. So with how much money in the intervention, decrease how much TF is also there for the WHO and others. And looking that one, we'll propose to escalate to other places. So with $1, we can just decrease one TF or something, then the recommendation is there for Minister of Health or something to nationwide, otherwise even globally to other study countries, to other countries with high prevalence. So we wait for that as well. Being effective and eliminating by itself may not be a reason just to escalate these things. We have to look these things, and this is a study. Maybe we'll compile and we'll finish this by this year. So this is also another thing. So even the response for the next escalation depends based on this, but we'll present this finding to WHO. And the final one is Do you think instability affects the intervention? It makes us just to work more, but the instability and the strengthens or it improves the intervention or the research, I can say. Because if I explain, for example, 2 times MD and targeted treatment were just implemented with the order and facilitation of FANO. FANO is there at the town of Merhabit and it is under their control. And be sure that all the health extension workers should work hard. And if the intervention is low during our time, we'll punish you. And what can we assist you? And the only thing is not to use smartphone because it may detect the GPS and so on. Otherwise, in hard copy, we know that the town is under government or the military force, but the neighbor or the companies are under farm. But they will support and they know everything the intervention. So no effect at all, and it's also even the achievement is high. Thank you.
Thank you. Okay, thank you very much for the comments and the questions that are very important for upgrading the manuscript later. When it comes to the ITVARC's doubt, yeah, we try to see the difference among the school type, private and government, the male and female. But we didn't see the difference among the age because the participants were from grade 7. All the participants in the control group and the experimental group were from grade 7. So age is not that much relevant for our study. For Dr. Mulusau, yes, yeah, the definition for resilience, yeah. The definition for resilience may be related with adaptability. It may be bounce back from adversity and so on. But our intention is how children or students can have strong psychological capability to adapt that situation because still ብዙ ነገር ነው አለ የሚሰሙት ይሰማሉ ያያሉ በጣም ብዙ ያው ጦርነቱን ባይኖር የሚወራው በጣም ብዙ ነገር ስለሆነ ማለት ነው እና ያንን አዳፕት አድርገው እንዴት ነው ትምህርታቸውን በአግባቡ መቀጠል የሚችሉት የሚለው so we link the definition of resilience with adaptability of the situation. Why resilience? Yes. By the way, resilience is if we define with regard to adaptability, if we help them to capacitate or to strengthen their psychological strengths so that they can function well in their day-to-day education system or activity personally. ምክንያቱም የሰዎችን ጥንካሬ አይበገሬነት so that they can challenge the challenge and there is a green light for that. So we will again continue to intervene and then we will try to check later on this. Recommendation, yes. Yeah, in order to make the intervention is sustainable, responsible, the stakeholder should stretch their hands to there so that we can help children to strengthen their capability. So the training should be since we can provide so that they can support their children in addition to the academics. So that is one of the means. So we will continue the training. So training is one means of or one strategy to support children, and we will establish a support group in every schools. Okay, and the schools that we intervene, and we will continue to again establish support groups at schools containing representative children, students and teachers. We will also have a plan to establish a club, mental health club that also constitutes teachers and students so that they can deliver at least mental health service at least at the first aid level. Thank you very much.
More clarification? Thank you. ወይም ደግሞ ፕሬዠሩ አለ እና ከዚያ ጋር ዲፊኒሽኑ እነዚያ ሞዳሊቲስ ካፓሲቲ
ብትሰጧቸው በጣም ኢንተረስቲንግ ነው ብዬ ስላሰብኩ ነው። እና እንትኑን ግን የማግኒቲዩዱን ብታስጠብቀው አንደኛ ቤዝ ላይ የነበረው ዘንድ ትሬኒንግ ሰጣቸው ስንል ኢንተርምስ ኦፍ ያም የተወሰነ ሳይድ ማሳየት አለበት። አሁንም እስቲ ቤዝ ላይ ያገኘነው ከቀጠለ የትሬኒንጋቸው አንድ ኮሽን ይሆናል። ተሻሽሎ ካገኘነው ግን የእናንተ ኢንተርቬንሽን ራይት ነው ማለት ነው። ለእናንተም እንደ ፊድባክ ስለሆነ እሱ ማናውት ካለ
Okay, thank you. Any analyst or okay. Now we do have any. So we like to appreciate your participation, your questions, a very hot session, very appreciated. Just like we expect from the academic perspective and weak set type of participation. So just research by a single person may not be comprehensive. So that needs to be supported by other experts. So we appreciate your participation and also we would like to appreciate your courage and your commitment and your presentation, your responses is very great, and we have learned a lot from you. And we invite you to enjoy with our beautiful city, Bahar Dar. And thank you for coming again. Thank you very much.
ሪሰርቸር ሊሆኑ ይችላሉ። አሁን ፕሬዘንቴሽን አለ አለ እሱም ተው ሚኒማይዝ አድርገው ፕሬዘንቴሽን አለ። ይህን እኮ ነው ቅድም አድርጌዋለሁ ስትል ለካ ፓወር ፖይንቱን ነው ያደረገው። ይቺ ፉል ስክሪኗን ሳናረጋት እንትን ላይ ይሄ ነው የመጣው።
ዞሮ የት እንትን እያለ አይደለም እኮ የሚሰራው ስለሆነ
ሲጨርስ እንደዚህ ነው
ትክክል አይደለም እንትን
ኮኔክሽኑ እና እንዴት ነው አሁን አለ እንደ ፕሬዘንቴሽን መጨረስ እስቲ እንትኑ ላይ ግባ እስኪ ይሄን ዝግ ጋር ላይ ግባ እስኪ
ታየ እንትሯ ነው ፖይንተሯ
ጨረስን እንትን ፕሬዘንቴሽን የለም እንደ እንትኗ
ከዚህ በኋላ ጨርሰናል። ታየ ከዚህ በኋላ ምንም ነገር የለም ጨርሰናል አይደል ቤቲ?
ስለዚህ ሎጋውት ይሄንን እንትን በለው እስኪ ይሄ እስኪ ስቶፕ በለው እንጂ ወይኔ ስቶፕ ከት ይደረጋል እዛ ሎካሊ እኮ ሪከርድ እንዲደረግ ስለተፈለገ ብዙ ሚኒማይዝ አድርገው እስኪ መቀመጡን ብቻ ነው የተከፈተው ቪዲዮ ካልቻልም በቃ ያለተው የዛሬ ቀን ስንት ነው? ይቺ ናት። ይሄ ነው ተው አራት
determinant in affecting their development in general, and that's also affects particularly the mental health.